Good morning, ladies and gentlemen. I'm Dr. Armen. Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. We continue to talk about heart failure. This is the third lecture dedicated to heart failure. Prognosis. So generally, patients with heart failure have a poor prognosis unless the cause is correctable. 5-year survival after initial hospitalization for heart failure is about 35%, regardless of the patient's ejection fraction. In overt chronic failure, obvious chronic failure, heart failure, mortality depends on severity of symptoms and ventricular dysfunction and can range from 10 to 40% a year. Specific factors that suggest a poor prognosis include hypertension, low ejection fraction, presence of coronary artery disease, coronary artery disease, obviously, troponin release, elevation of BUN, so brain natriuretic peptide, reduced glomerular factors, GFR, hyponatremia, and poor function capacity, for example, attested by a 6-minute walk test. So BMP, NT-proBNP, and risk scores such as MAGIC risk score and the Seattle heart failure model are helpful to predict prognosis in heart failure patients as an overall group, although there is a significant variation in survival among individual patients. Heart failure usually involves gradual deterioration interrupted by bouts of severe decompensation and ultimately death, although the time course is being lengthened with modern therapies. However, death can also be sudden and unexpected without prior worsening of the symptoms. And we have to understand this is end-of-life care. End-of-life care. So all patients and family members should be taught about disease progression and the risk of sudden cardiac death. For some patients, improving quality of life is as important as increasingly quantity of life. Thanks to the authors. Improving quality of life is as important as increasing quantity of life. Thus, it is important to determine patients' wishes about resuscitation, for example, endotracheal intubation, cardiac pulmonary resuscitation, respiration, of course, if their conditions deteriorate, especially when heart failure is already severe. All patients should be reassured that the symptoms will be relieved, and they should be encouraged to seek medical attention early if their symptoms change significantly. Involvement of pharmacists, nurses, social workers, and clergy, if desired, of course, who may be part of an interdisciplinary team or disease management program already in place is particularly important in end-of-life care. So treatment of heart failure, diet and lifestyle changes, it's absolutely necessary. Treatment of cause, drugs, numerous classes, sometimes device therapy, for example, implantable cardioverter defibrillator, cardiac resynchronization therapy, mechanical circulatory support. Sometimes cardiac transplantation, actually very questionable. multidisciplinary care. Immediate inpatient treatment is required for patients with acute or worsening heart failure due to certain disorders. For example, acute myocardial infarction, atrial fibrillation with a very rapid ventricular rate, severe hypertension, acute valvular regurgitation, as well as for patients with pulmonary edema. Severe symptoms, new onset of heart failure, or heart failure unresponsive to outpatient treatment. Patients with exacerbations of previously diagnosed heart failure can be treated at home. The primary goal is to diagnose and to correct or treat the disorder that lead to heart failure, of course. And that is why we talk about goals. So primary goals, once again, is to diagnose and to correct or treat the disorder that lead to heart failure. So we've got short and long-term goals. So short-term goals include relieving symptoms and improving hemodynamics, avoiding hypokalemia, renal dysfunction, and symptomatic hypertension, and correcting neurohumoral activation. Catecholamine in intoxication. It's my term. Yes. Long-term goals include correct hypertension, preventing myocardial infarction and atherosclerosis, improving cardiac function, reducing hospitalizations, and improving survival and quality of life. So my students that know my lectures, or my colleagues that know my lectures, know that I repeat it several times and I will repeat once again. We have to understand all this continuum. So we're starting with metabolic in very young age. The problems start with metabolic syndrome with inflammation, then continues. So like box in boxes in boxes, or like Russian matryoshka. So the first box is a metabolic syndrome with inflammation. We open this box, we take another box, little one. This is atherosclerosis. Of course, hypertension also one of the boxes of metabolic syndrome, of course. Or, for example, diabetes mellitus or gout with hyperuricemia, hypercholesterolemia, etc., etc. But we talk about this chain, atherosclerosis. Then we take another box in the atherosclerosis and we find what we find in cardiovascular diseases. And in cardiovascular diseases we find another box, coronary artery disease. Another box in coronary artery disease is the first signs of complaints, first signs of all this iceberg. First sign is angina. In another box is acute coronary syndrome. In an acute coronary syndrome we find myocardial infarction, no matter what myocardial infarction, and this end with heart failure. So we understand that treatment of all this problem is we have to start from metabolic syndrome, and treatment of metabolic syndrome is the actually changing of lifestyle. So treatment involves dietary and lifestyle changes, drugs, devices, and sometimes percutaneous coronary interventions or bypass surgery. Treatment is tailored to the patient, considering causes, symptoms, and response to drugs, including adverse effects. There are currently several evidence-based therapies for chronic heart failure with reduced ejection fraction. There are few evidence-based treatments for chronic heart failure with preserved ejection fractions, acute heart failure syndromes, and right ventricle failure. So disease management, so general measures, especially patients are caregiver educations and caregiver. So caregiver education and diet and lifestyle modifications are important for all patients with heart failure. So actually, we understand. So you understand, I suppose, all this chain, and we have to educate patient and his or her caregiver, givers. So first of all, this is of course education. Sodium restrictions, actually it's a little bit questionable. Appropriate weight and fitness levels. Correction of underlying conditions. Patient and caregiver education are critical to long-term success. So these all patients with heart failure, they are all patients of care. The patient and family should be involved in treatment choices. They'd have to be your cooperator. They should be taught the importance of drug adherence, compliance. Warning signs of an exacerbation, and how to link cause with effect. For example, increased salt in the diets with weight gain or symptoms. With salt, let's be a little bit no as previous years. Yes, salt restriction is okay, but not as strict as we thought previously. Many centers, for example, specialized outpatient clinics, have integrated healthcare practitioners from different disciplines. For example, nurses, heart failure nurses, pharmacists, social workers, rehabilitation specialists, into multidisciplinary teams or outpatient heart failure management programs. This approach can improve outcomes and reduce hospitalizations, and are most effective in the sickest patients. So, monitoring daily morning weight helps detect sodium and water accumulation early. If weight increases more than 2 kg over a few days, patients may be able to adjust their diuretic dose themselves. But if given gain continues or symptom occurs, patients should seek medical attention. So intensive care management, particularly by monitoring drug adherence and frequency of unscheduled visits to the physician or emergency department and hospitalizations, can identify when intervention is needed. Specialized heart failure nurses are valuable in education follow-up and dosage adjustment according to predefined protocols. Patients with atherosclerosis or diabetes should strictly follow a diet appropriate for their disorder. Obesity may cause and always aggravates the symptoms of heart failure. Patients should attain a body mass index less than 30 kg per meter square. Ideally. About regular life activity, for example, walking, tailored to symptoms, is generally encouraged. Activity prevents skeletal muscle deconditioning. It's very important. Not only skeletal muscle deconditioning, even heart deconditioning, myocardium deconditioning, which worsens functional status. However, activity doesn't appear to improve survival or decrease hospitalizations. Questionable. Rest is appropriate during acute exacerbations. Formal exercise cardiac exacerbation is useful for chronic heart failure with reduced ejection fraction, and is likely helpful for patients with heart failure with preserved ejection fraction. Patients should have annual influenza vaccinations because influenza can precipitate heart failure exacerbations, particularly in institutionalized or older patients. If cases such as hypertension, persistent tachyarrhythmia, severe anemia, hemochromatosis, uncontrolled diabetes, thyrotoxicosis, beriberi, alcohol disorder, or toxoplasmosis are successfully treated, patients may dramatically improve. Yes, significant myocardial ischemia should be treated aggressively. Treatment may include revascularizations by percutaneous coronary intervention or bypass surgery. Management of extensive ventricular infiltration, for example in amyloidosis, has improved considerably. Newer treatment for amyloidosis have markedly improved prognosis for many of these patients. Concerning drug treatment of heart failure involves symptoms relief. So, of course, this is diuretics, the king of the treatment heart failure, diuretics, nitrates or digoxin. So once again, diuretics, nitrates or digoxin. Long-term management and improved survival, angiotensin converting enzyme, AC inhibitors. Beta blockers, of course, aldosterone antagonists, angiotensin 2 receptor blockers, Zartans. So Zartans. When we talk about angiotensin 2 receptor blockers, I will talk about Zartans. Angiotensin receptor nephrilisin inhibitors, ARNI. Okay, so ARNI is angiotensin receptor nephrilisin inhibitors, ARNI. And sodium glucose cotransporter 2 inhibitors. Or why not sinus node inhibitors. So in heart failure, if all these drugs with reduced heart ejection fractions, so systolic dysfunction, reduced. So in heart failure with reduced ejection fraction, all these drugs mentioned above classes have been studied and have shown benefit for long-term management. Addition to a sodium glucose cotransporter 2 inhibitor, dapagliflozin, has been shown to reduce morbidity and mortality when added to standard care in patients with elevated natriuretic peptide levels. Benefit was similar in patients with and without diabetes. In heart failure with preserved ejection fraction, so we talk about diastolic dysfunction. So in heart failure with preserved ejection fractions, fewer drugs have been adequately studied. However, AC inhibitors, Zartans, or aldosterone antagonists, minicalocorticoid receptor antagonists, are generally used to treat heart failure with preserved ejection fractions. ARNIs may reduce hospitalizations for heart failure but do not improve other outcomes. Randomized controlled trials suggest aldosterone antagonists are beneficial, but nitrates probably are not. Not probably, they are not. Beta blockers should be used only when there is another existing indication. For example, control of heart rate during atrial fibrillation, angina following myocardial infections. In patients with severe heart failure with preserved ejection fraction, in contrast to heart failure with reduced ejection fraction, lowering the heart rate, for example with a beta blocker, can exacerbate symptoms because these patients have a relatively fixed stroke volume due to severe diastolic dysfunction. In these patients, cardiac output is heart rate dependent, and lowering heart rate can thus lower cardiac output at rest and or with exertion. But if you can give beta blockers, even a very small doses, it will be fantastic. If not, no. So in heart failure with mixed ejection fraction, not preserved, not reduced, there may be a specific benefit from ARNIs, although this possibility requires further prospective confirmation. In patients with infiltrative, restrictive or hypertrophic cardiomyopathy, digoxin is not effective and may be harmful. Digoxin is not effective and may be harmful. In addition, vasodilator. So vasodilator therapy may also be poorly tolerated and has not shown benefit in these patients. All patients should be given clear and explicit information about their drugs, including the importance of timely prescription renewal and adherence to therapy, how to recognize adverse effects, and when to contact their physicians. Arrhythmias. It's important to identify and treat the cause of an arrhythmia. So electrolytes are normalized, atrial and ventricular rates are controlled, sometimes antiarrhythmic drugs are given. Sinus tachycardia, a common compensatory change in heart failure, usually subsides when heart failure treatment is effective. If it does not, associated causes, for example, hyperthyroidism, pulmonary emboly, fever, anemia, pain, should be sought. If sinus tachycardia persists despite correction of causes, a beta blocker given in gradually increasing doses may help selected patients. However, lowering heart rate with a beta blocker can be detrimental to patients with advanced heart failure with preserved ejection fraction, for example, in restrictive cardiomyopathy, in whom stroke volume is fixed because of severe diastolic dysfunction. In this patient, cardiac output is heart rate dependent, and lowering heart rate can thus lower cardiac output and or with exertion. So atrial fibrillation with uncontrolled ventricular rate must be treated. The target resting ventricular rate is typically less than 80 beats per minute. Beta blockers are the treatment of choice, although rate-limiting calcium channel blockers may be used cautiously if systolic function is preserved. Adding digoxin, low-dose amiodarone, or other treatment or rate-controlling drugs may help some patients. Routine conversion and maintenance of sinus rhythm has not been shown to be superior to rate control alone in large clinical trials. However, it's best to make this determination on a case-by-case basis because some patients improve significantly with restoration of normal sinus rhythm. If rapid atrial fibrillation doesn't respond to drugs, permanent pacemaker insertion with complete or partial ablation of the ventricular node or other atrial fibrillation ablation procedures may be considered in selected patients to restore a sinus or regular rhythm. Isolated ventricular premature beats, or ventricular extrasystole, which are very common in heart failure, doesn't require specific treatment. Although rarely very frequent ventricular premature beats, very frequent, so more than 50,000 a day, have been shown to precipitate heart failure that reverses with suppression. However, optimization of heart failure treatment and correction of electrolyte abnormalities, especially potassium and magnesium, reduce the risk of ventricular arrhythmias. Sustained ventricular tachycardia that persists despite correction of cause, for example, low potassium or magnesium, ischemia, and optimal medical treatment of heart failure may require an anti-arrhythmic drug. Amiodarone, beta blockers, and dofetilide and dofetilide are the drugs of choice because there are other antiarrhythmics have adverse proarrhythmic effects when left ventricle systolic dysfunction is present. Because amiodarone increases digoxin, and warfarin levels, digoxin and or warfarin should be decreased by half or stopped. Serum digoxin level and INR, international normalized ratio, into ENR level should be routinely monitored. However, drug toxicity can occur even in therapeutic levels. Because long-term use of amiodarone can cause adverse effects, a low dose 200 mg orally once a day is used when possible. Blood tests for liver function and thyroid-stimulating hormone are done every 6 months. Blood tests for liver function and thyroid stimulating hormone are done every 6 months. If chest X-rays is abnormal or dyspnea worsens significantly, chest X-ray and pulmonary function tests are done yearly to check for pulmonary fibrosis. For sustained ventricular arrhythmias, amiodarone may be required to reduce risk of sudden death. A loading dose of 400 to 800 mg orally twice a day is given for 1 to 3 weeks until rhythm control is adequate. Then dose is decreased over 1 month to maintain dose of 200 mg orally once a day. So about devices. Use of implantable cardioverter defibrillator or cardiac resynchronization therapy is appropriate for some patients. So implantable ICD. What is ICD? ICD is implantable cardioverter defibrillator. So an ICD is recommended for patients with an otherwise. So I'm sorry for this call. This call for the emergency. Okay. So an ICD. ICD is once again. ICD is recommended for patients with otherwise good life expectancy if they have symptomatic sustained ventricular tachycardia or ventricular fibrillation, or if they remain symptomatic and have left ventricle ejection fraction, persistently less than 35 percent, of course, while receiving guideline-directed medical therapy. The data of ICD, implantable cardioverter defibrillators, used in heart failure with reduced ejection fraction are stronger for ischemic cardiomyopathy than in non-ischemic cardiomyopathy. A recent clinical trial that included heart failure with reduced ejection fraction patients with non-ischemic cardiomyopathy demonstrated no mortality benefit from prophylactic primary prevention ICD placement. So cardiac resynchronization therapy, CRT, may relieve symptoms and reduce heart failure hospitalizations for patients who have heart failure, left ventricle ejection fraction less than 35%, and a widened QRS complex with a left bundle branch block pattern more than 0.15 second. How they say, yes, 0.15 second. The wider the QRS, the greater potential benefit. CRT devices are effective but expensive, and patients should be appropriately selected. Many CRT devices also incorporate an ICD in their mechanisms, of course. An implantable device that remotely monitors invasive hemodynamics, for example, pulmonary artery pressure, may help guide heart failure management in highly selected patients. For example, diuretics. The traditional based on the readings from one of these devices was associated with a marked reduction in heart failure hospitalization. In one clinical trial that included patients with both heart failure with reduced ejection fraction and preserved ejection fraction. The device uses the pulmonary artery diastolic pressures, are a surrogate for a pulmonary capillary wedge pressure and hence left atrial pressure in heart failure patients. However, it has been evaluated only in New York Heart Association NUHA class 3 patients who had recurrent heart failure exacerbations. Okay? Further evidence would help guide how this technology should be implemented. Will help us. We will see. Ultrafiltration, so veno-venous filtration, can be useful in selected hospitalized patients with severe cardiorenal syndrome and volume overload refractory to diuretics. However, ultrafiltration should not be used routinely because clinical trials do not show long-term clinical benefit. An intra-aortic counterpulsation bellum pump, so we will talk about just pump, intra-aortic counterpulsation bellum pump, so pump, is helpful in selected patients with acute heart failure who have a good change on recovery. Good change of recovery, for example, acute heart failure following myocardial infarction, or in those who need a bridge to more permanent solutions, such as, for example, cardiac surgery. For example, to fix severe valvular disease or to revascularizate multivessel coronary artery disease, and left ventricle assist device or heart transplantation. Other forms of temporary mechanical circulatory support for patients with acute heart failure and cardiogenic shock include surgically placed devices such as extracorporeal membrane oxygenation, ECMO, typically veno-arterial cannulation, centrifugal flow ventricular assist device that can support either the left ventricle, the right ventricle, or both, and can also be combined with an oxygenator to provide full cardiopulmonary support. Percutaneously placed devices such as intravascular microaxial ventricular assist devices are available for both left ventricle and right ventricle support. Selection of temporarily mechanical circulatory support devices is based mainly on availability and local medical center experience. Durable or ambulatory left ventricle assist devices, LVAD, and long-term implantable pumps that augment left ventricle output. They are commonly used to maintain patients with severe heart failure who are awaiting transplantation and are also used as destination therapy, so-called. That is a long-term of permanent solution, and some patients who are not transplant candidates. So surgery and percutaneous procedures. Surgery may be appropriate when certain underlying disorders are present. Surgery in patients with advanced heart failure should be done in specialized center, even without advanced heart failure. All surgeries is in specialized centers, of course. Surgical closure of congenital or acquired intracardial shunts can be curative. So coronary artery bypass grafting CABG for patients with left ventricle systole, dysfunction secondary to coronary artery disease, and evidence of myocardial viability may be beneficial. However, those patients with prior myocardial infarction and non-viable myocardium are less likely to benefit from CABG. Thus, the decision to revascularize a heart failure patient with multivessel coronary artery disease should be made on a case-by-case basis. Case by case. In heart failure, if heart failure is primarily due to a valvular disorder, valve repair or replacement should be considered. Patients with primary mitral regurgitation are more likely to benefit than patients with mitral regurgitation secondary to left ventricle dilation, in whom poor myocardial function is likely to continue post-operatively. Surgery is preferably done before myocardial dilation and damage become irreversible. More recently, percutaneous mitral valve repair procedure, in which a clip applied to approximate the anterior and posterior mitral leaflets, has been shown to reduce death and heart failure hospitalization in carefully selected patients with symptomatic heart failure despite optimal medical management and moderate to severe or severe mitral regurgitation, with preserved left ventricle size and systolic dimensions to less than 70 millimeter. Heart transplantation is the treatment of choice for patients less than 60 who have a severe refractory heart failure and no other life-threatening conditions and who are highly adherent to management recommendations. Some older patients, about 60 to 70 years with otherwise good health, are also typically considered if they meet other criteria for transplantation. Survival is 85 to 90% at 1 year, and annual mortality thereafter is about 4% a year. However, mortality rate while waiting for a donor is 12 to 15%. Human organ donation remains low. So anemia and iron deficiency. Anemia is common among patients with chronic heart failure and is frequently multifactorial. Anemia is associated with worse symptoms and outcomes in heart failure, and so reversible causes should be sought and treated. Iron deficiency is among the most common causes of anemia in heart failure, and iron replacement therapy should be considered once treatable causes such as blood loss, gastrointestinal or other have been excluded. Normal alimentation. Oral iron replacement is often less effective due to poor absorption and other reasons, yes, thus intravenous iron replacement is preferred. A persistent heart failure. After treatment, symptoms often persist. Reasons include persistence of the underlying disorders, for example, hypertension, ischemia, infarction, valvular disease, despite treatment, suboptimal treatment of heart failure, drug in non-adherence, so compliance, non-adherence to drug, very, very common, the most common case. Excess intake of dietary sodium or alcohol, dietary sodium maybe. Presence of an underdiagnosed thyroid disorder, anemia, or supraevening arrhythmia. For example, atrial fibrillation with rapid ventricular response, intermittent ventricular tachycardia. Also, drugs used to treat other disorders may interfere with heart failure treatment. Non-steroidal anti-inflammatory drugs, thiazolidinediones, actually pioglitazone. Pioglitazone for diabetes. Yes. Thiazolidinediones. Oh, I'm not arrived. So for pioglitazone for diabetes and short-acting dihydropyridine or non-dihydropyridine calcium channel blockers can worsen heart failure and should be avoided unless two alternatives exist. Patients who must take such drugs should be followed closely. Okay, so key points. Actually ending. Heart failure involves ventricular dysfunction, which ultimately leads to the heart not providing tissues with adequate blood for metabolic needs. In heart failure with reduced ejection fraction, the ventricle contracts poorly and empties inadequately, so ejection fraction is low. In heart failure with preserved ejection fraction, ventricular filling is impaired, resulting in increased end diastolic pressure and rest and/or during exercise. Ejection fraction is normal. Consider heart failure in patients with exertional dyspnea or fatigue, orthopnea and/or edema, particularly in those with a history of myocardial infarction, hypertension, or valvular disorders or murmurs. Do chest X-ray, ECG, BNP levels, and an objective test of cardiac function, typically echocardiography. Unless adequately treated, heart failure tends to progress and has a poor, very poor prognosis. Treatment includes education and lifestyle changes, control of underlying disorders, a variety of drugs, and sometimes implantable devices. CRT, ICDs. So that's all. Yes, my friends, that's all concerning heart failure. Thanks you for your attention. Please don't forget to make your donations, my dear friends, because without your donations we can't exist once again. So thanks to everybody to make their donations. So how to make these donations? So find in description of this video in YouTube, just in description, how to donate. For donate there are three options. So you could choose any you want. So MasterCard, or you could find my first account, but it's in Russian, Ugolok Doktora. Find and you can become a friend of Уголок доктора. So if you find this channel, and yes, of course, this is in Russian, you can find this channel and subscribe and make your donations directly. So so to be a sponsor, I forgot the name of sponsor, to be a sponsor of Уголок доктора. So Уголок доктора and healthcare and education, this is the same channel. So one in English, one in Russian, so our channels. So we can become a sponsor. Just choose your possibilities to become a sponsor. So that's all concerning heart failure, concerning this lecture. See you in other lectures. Don't forget to follow and subscribe. Make your donations. And put ring on to be in touch with all news from our channel. So goodbye and God bless you.